Hello, I'm Dipti Chaporia, and I'm the Vice President for the American College of Cardiology. And I'm here to welcome you and thank you for joining us today for the ACC's Middle East 2020 webinar series. This is our third in our webinar series, where we're going to be addressing the contemporary management of aortic valve disease. While I think while I wish that we could all be together today, I think the world seems to have other plans for us this year. So on behalf of the ACC, I sincerely appreciate the time that you're all taking from your busy schedules to join us today. And before I close and we start the program, I'd like to thank the planning committee that includes Dr. Mohammed Sobi and Dr. Magdi Abdelhamid. And I want to say a special thank you to Dr. Sobi, who has been my partner throughout this whole Middle East series from the beginning, as I've been the chair of the Middle East Conference for the last 2 years. So I look forward to continuing more work in the Middle East with all of our educational series when I become president for ACC next year. So I'm going to hand it over to Dr. Sobi, and thank you very much for joining us. And I hope you enjoy our webinar series today. Dr. Sobi?
Yeah, thank you, Deputy, for a nice introduction. Actually, it's my pleasure to join you since a long time to work with international affairs, and your effort is very evident to all of us. And I think it's good for the ACC to have the second lady now after Athene Poupé, Deputy, in February in beginning of March to be the president, and I hope we can work. The idea come from just we have before the ACC Middle East 20, it's supposed to be in October, but we decided because of the COVID pandemic to make it 2021. But during this period, we decided at the board, me, Deputy, and Dr. Magdi, to have this kind of webinars. Actually, the project overview, it's an online meeting surrounded by our shared commitments, the ECC and ECC chapters in Egypt, to deliver engaging forum to critically examine the evidence-based strategy and contemporary best practice and clinical decision-making to reach our common objective of improving health of the patient cardiovascular disease. The project objective is the global experts, then local learnings to lead the way, and power your mind through the finding of the practical solution, and finally, the conversation through creating connections. We divided in our way to 4 waves. The wave 1 main topics was managing complex patients with acute coronary syndromes, that's heart failure, established and emerging therapy. This is the statistics of EDIT edition 1. It's 441 viewers with 2 sessions, 4 topics, 8 experts, and 2 symposiums, about 39 countries attending these webinars. In wave 2 main topics, contemporary therapies for hypertension and dyslipidemia, and then therapeutic options for treatment atrial fibrillation. Again, also 508 viewers, 2 sessions, 4 topics, 8 experts, and more than 42 countries attending this wave 2. The dates, now we have wave 3, but maybe I promise you for the webinar 4, which is Saturday, November 21, again, also to 8:30 to 10 p.m. Don't forget and save the date and stay tuned, because we are preparing, next week, we are going to prepare another program for you, which is the big ACC Middle East 2021, which will be in Cairo, Egypt, October 14th, 15, with the pre-conference October 13. Thanks to our sponsors for all these waves, for these waves, Medtronic and Pfizer for the first 3 waves, will be the 4th wave as well. And this is also thanks to ICOM company for technical support and preparation of the meetings. Today's scientific programs we divide into 3 topics in the contemporary management of aortic valve disease, from imaging to interventions. We have 2 from United States, Dr. Heba Wasif and Dr. Wael Jabbar. And from Egypt, you have Dr. Iman Sharawi, Dr. Khaled Shokri, and Dr. Yasser Sadeh. Me and Deputy will stay till the end with you, mute, and then we have the closing remarks. Thank you very much for your attendance, and I hope we have a discussion in between the lectures for the imaging, for the interventions, because we choose this aortic valve because it is I think the valve of the day, and becomes contemporary management for every patient with aortic valve now, maybe from low risk to high risk to very high risk patients, and be a challenging case by Dr. Yasser. Thank you very much. I leave the mic to Dr. Heba Wasif.
Thank you, Dr. Subhi. Thank you, Dr. Ishapuria. Thank you for the invitation. It's my pleasure to be a moderator for this session today of contemporary management of aortic valve disease from imaging to intervention. And our first speaker is Dr. Wael Jabr, my colleague, who is the medical director of cardiovascular imaging and of the core laboratory at the Cleveland Clinic, and a very well-known researcher, authorized multiple articles in circulation, in JACC and other journals, and an excellent teacher. And I'm sure we're looking forward to his presentation today. Dr. Jabr.
Thank you, Hiba. This is a great opportunity, and thank you everybody for joining us this afternoon. I have a task of covering a great topic, and that's going to go probably over the next 15 minutes. Again, I thank the ACC Egypt. I thank my ACC mother company here in the US, and Dipti has been a fantastic supporter for all the activities and teaching around the world. The task I have is not small, and it will take probably another full symposium or probably a couple of days of symposia. So we're going to talk about management of imaging for management of aortic stenosis. First, I have two conflicts. I'm the EchoCore Lab Director for the partner trials. Doing that for about 9 years right now. I get no direct compensation from that activity. It all goes to my institution. The first issue that we have to know about is that aortic stenosis, as we all know, is a progressive disease. So how to use imaging for monitoring that disease and diagnosing the disease. It is a treatable disease, as has been mentioned in the introduction. How to use imaging to decide on treatment and timing of treatment. It is a confusing disease, sometimes, as we've been learning in the past few years, especially in patients with low flow, low gradient AS, low flow, low gradient normal ejection fraction aortic stenosis, and how to use imaging to get some clarity. Just as a reminder, beyond the physical exam and the stethoscope, central and indispensable role of echocardiography should be acknowledged for this. We have a newly established role of CT, which is keeps evolving. And if I give you a talk about it today, in about 6 months, there'll be some new things in CT that will enlighten us more about aortic stenosis. There is an emerging role for MRI to fine-tune the timing for intervention aortic stenosis, specifically with looking for fibrosis. And finally, with nuclear imaging, there is also a role for technetium pyrophosphate for detection of ATTR and aortic stenosis and how to manage these patients. So let's start with echocardiography. Echocardiography has been indispensable from the beginning in establishing the anatomy. Establishing anatomy for normal valves, rheumatic valves, as you guys see in the Middle East and other parts of the world. Calcific aortic stenosis, aortic stenosis associated usually with the aging of the population, and congenital aortic stenosis for bicuspid valves, unicuspid valves, and others. The other role for echocardiography beyond anatomy is to establish whether stenosis is present or absent through gradients, through stroke volume index, and through aortic valve area. Now let's start with aortic stenosis for gradients. The most important part, and this is from the American Society of Echocardiography guidelines, is this LVOT velocity. We used to look at it only in terms of as a component of the calculation of aortic valve area, but now we use it more and more for calculation of stroke volume index for aortic stenosis. These are general guidelines of how to obtain this very instrumental and very important variable. If you don't do it right, you'll end up with a lot of variability and a lot of, confusion of whether the stenosis is present or not, and what's the contribution of the stroke volume to it. Then we talk about continuous wave echocardiography for jet velocity and for gradients across the valve through the continuity equation, that also is important in terms of follow-up, in terms of timing of follow-up, in terms of addressing the progression of disease. And these are some general guidelines how to get these gradients. Then we move to one of the most probably controversial issues with aortic stenosis, which is left ventricular outflow tract measurements. The problem with that is echocardiography is a two-dimensional representation in general of a three-dimensional structure. We have struggled with this for probably the better of the past quarter century in figuring out what is the true left ventricular outflow tract measurement, the correct one. Traditionally, we've measured it in the way it's displayed on the screen here, but you can see just moving the arrows up and down by 1 or 2 millimeters, you can get totally different LVOT measurements. There are some specific guidelines for that. If you're lucky to get good echocardiographic images, you can actually get reliable LVOT measurements. Then we move from all these things that I presented to you to derive. Now we can derive gradients across the valve, aortic valve area across the valve, what is the true aortic valve area, and finally we can decide whether there's presence of stenosis or no stenosis, and where the stenosis is. Is it mild, is it moderate, or is it severe? Now, whenever you have a table like this, you can imagine that you can have discordances, and we can talk about them later, where you can have a patient presenting with a mean gradient of 20 to 40, but a valve area under 1. So those are the cases where you have to actually use your judgment and use other imaging modalities to decide whether stenosis is present or absent and how bad it is. Beyond the diagnosis of aortic stenosis, echocardiography is essential to rule out other etiologies of high LVOT gradients, namely hypertrophic cardiomyopathy with obstruction or the presence of membranes. So this is an example of a patient who was sent to us in the past 2 months for aortic valve stenosis. And you can see here, this patient has a gradient that's late in systole, that's not early in systole, a late peaking gradient caused by systolic anterior motion of the mitral valve and the presence of hypertrophic cardiomyopathy. This is obviously not aortic stenosis. This is subaortic stenosis. Another form of subaortic stenosis is this form here, where you can see there is a clear membrane across the LVOT, causing turbulence and a gradient across the valve. And on the right-hand side, you can see that the aortic valve actually opens quite well. So this is, again, another role for echocardiography, not to trust only the gradients, but to look for the anatomy and for all the other things that can cause LVOT obstruction. Now, once you have a good echocardiogram and everything is concordant, you don't need to move towards TEE or any of these things. But if you have discordance in the measurements of gradients versus the aortic valve area, if you have uncertainty about the LVOT, transphageal echo is a good tool to use, and we use it very aggressively at our center in some of these confusing cases. Now, one thing is, it's very good to determine the valve anatomy. It's much clearer image. You can be more precise. We used it initially in the past maybe 15, 20 years for planning for TAVR and for guiding TAVR. This is now a very diminishing role. I can't remember the last time I was called to the operating room or the cath lab to assist with a TEE in the setting of a TAVR. All of our TAVRs right now, almost all of them, are done under conscious sedation, no TEE, and with just surface echocardiography at the end of the procedure to ascertain the location of the valve and the absence of aortic valve regurgitation or complications. So this is a diminishing role. Some centers still use it, but at our center, at least, we moved away from it to make the procedure less traumatic to the patient. In the case you use a transphageal echo, in some cases, you can see here, you can actually precisely, especially with 3D TEE, you can precisely measure the LVOT quite well and be sure where you are right underneath the valve and get actually an LVOT area besides the LVOT dimension that we used to. And here you can see an example of why the LVOT is problematic. It's an ovoid-shaped structure, not a circular structure. Again, with the 3D transphageal echocardiography, you can actually measure the valve area, as you can see right here, with some precision, better than surface echocardiography, because you can actually make sure that you are at the tips of the valve, not way in the body of the valve when you're measuring the aortic valve area. Beyond anatomy and diagnosing of severe aortic stenosis, echocardiography is instrumental, and it's part of the guidelines, actually, for monitoring the disease progression. You can start from a normal valve, and then you can progress all along to a sclerotic valve early in the disease, all the way to severe aortic stenosis, and you can do that by anatomy and by hemodynamics, as it's seen on the bottom of the screen. This is a busy table here, but the gist of it is to show you that if you use initial evaluation, clinical and echocardiographic evaluation, rarely cardiac catheterization these days for diagnosis of aortic stenosis, you can actually separate patients into mild aortic stenosis, moderate aortic stenosis, and then finally severe aortic stenosis. And in the severe, you can see the symptomatic versus the asymptomatic. And in that group of symptomatic and asymptomatic, echocardiography can be used as a guide to tell you when to repeat image these patients, can be used as a tool in addition to exercise treadmill to measure gradients across the valve, can also be used in dobutamine echoes and other ways to provoke a gradient across the valve. Whenever you're looking at an echo for aortic stenosis, don't forget about the companions of aortic stenosis, namely LV hypertrophy. If you have severe aortic stenosis without hypertrophy, try to check why is this happening, what's the confounding issue here. You can look for the LV size and function. In many cases, specifically patients with unicuspid valve and bicuspid valve, make sure you look at the aorta for dilatation and aneurysms, and look for other valvular pathology, specifically in patients with rheumatic heart disease. Now, as far as the entity of low flow, low gradient aortic stenosis, the old guidelines in 2009 were somehow vague. Now we have some clarity from the 2017 guidelines, where they tell you if the valve area is under 1, the mean gradient across the valve is under 40 millimeters Hg. These are all things that should at least make you think about the presence of low flow, low gradient aortic stenosis. So now, automatically, whenever we have these things, we look at the stroke volume index, and if it's under 35, there is something intrinsically wrong with the left ventricular contraction that leads to such a stroke volume that is low. Now, another busy table here. Ignore the part that's on the right, because that's all about high gradient aortic stenosis, and we all know how to deal with that, specifically in symptomatic patients. When we have low flow, low gradient aortic stenosis on the left-hand side, we have the first step is actually to exclude a measurement error, even if you have to repeat the echocardiography. Very often at our center, we get patients, they say it's a low flow, we sample the LVOT from a different position, suprasternal areas or a better apical window, and we find out that the gradients are actually much higher without going into the quagmire of looking at the stroke volume and other things. If we are sure that the stroke volume or the aortic stenosis is low flow, low gradient, we look for the stroke volume index, and from that on, we can actually see with dobutamine echo or with other tools whether that gradient changes and whether the valve area improves after administering dobutamine or remains severe. We move to the next imaging modality, which is CT. It's been instrumental for anatomy, for calcification, and for evaluation of aorta disease of the aorta beyond the aortic valve. Now, the first issue we talked about a little bit earlier, it is known right now that the echocardiography underestimate the LVOT by about anywhere 15 to 20% compared to CT, which is more anatomically precise. So CT right now, we liberally use it in almost every patient, unless there is a contraindication, who's planning to have a transfemoral aortic valve replacement TAVR. This is an example of how CT can be used. On top can be used for anatomic measurement of the valve area, and on the bottom you can see it here for measurement of left ventricular outflow tract dimensions and area. Very accurate, very good tool to do that, and I recommend it if you're planning to do TAVRs at your center. This is the way to go beyond echocardiography. Beyond the anatomic measurements, you should look at calcifications. These are some of the established guidelines, and this is from the American Society of Echocardiography, which should surprise you. They're using CT calcium scoring to tell you whether the valve is more likely to be severe in men and women with different thresholds. So a valve that has more than 2,000 score for calcification is more likely to be severe in men, and in females, that threshold is about 1,200. So it's a much lower threshold for females versus male. We often use it in confusing cases where we think that the valve is more severe or less severe than we have by echocardiography. This is a nice tool to utilize. Beyond the issue of discriminating between mild, moderate, and severe stenosis with calcification, this is a paper that was published a few years ago looking at prognosis from calcification. These are all patients who presented with severe echocardiographic aortic stenosis. And you can see the patients who have actually calcification on the valve did much worse than patients with less calcification on the bottom Kaplan-Meier survival curve. This is total survival. And this is adjusted for age, gender, and other confounding variables. So all these patients have aortic stenosis. Calcifications of the valve confer a much higher mortality than patients without calcification. Now, beyond the calcifications and the anatomy, make sure that you do, this is a CT done for planning for TAVR. We look for the LVOT, we look for the sinuses, coronary origins, and descending aorta and femoral axis. Again, a very nice, cool tool to plan for TAVRs. CT also emerged as a good and probably one of the best tools to look for thrombosis of the valve, this entity of Holt. This is an example of patient who pre and post anticoagulation for Holt. You can see it by CT here very nicely, very elegant, very hard to see it by transphageal echo, but precisely and well seen by CT scanning. You can also look for pannus formation, and you look for endocarditis. The third modality imaging is cardiac MRI. Cardiac MRI gives us this specific window at looking at histopathology of what's happening to the ventricle and this, at the cellular level with the progression of aortic stenosis, where we move from cellular hypertrophy to fibrosis, to replacement fibrosis, and finally to LV dilatation and heart failure and cellular death with apoptosis. These are two tools to look at that by MRI. You have first extracellular volume, and then you have late gadolinium enhancement. And patients who have these are all patients with severe aortic stenosis. Patients who have normal myocardium with no cell death, no fibrosis, did much better than patients who have extracellular expansion on MRI or replacement fibrosis. So now you can use MRI in all your populations coming with severe aortic stenosis, those who probably have some early evidence of cellular damage. Probably these patients should be sent for valve replacement. So this is how you can use MRI to fine-tune your decision-making on which patients to send for surgery. This is again from MRI. Again, you can see here with the progression of extracellular volume expansion, cardiovascular mortality goes up and all-cause mortality goes up. So now the challenge is to figure out how to incorporate this tool into our decision-making for aortic valve replacement, whether it's SAVR or TAVR. The last imaging modality, and there's two more slides about that, is nuclear cardiology. I never thought I would talk about nuclear cardiology and aortic stenosis. Now we use it very often at our center for two indications. This is a list of some of the studies done for patients with aortic stenosis and cardiac amyloidosis. You can see this one here in the middle is 71 patients from our center. Looking at this specific population, the incidence of cardiac amyloidosis with aortic stenosis ranges anywhere between 15 and 80%, and I will show you a slide about that later. Another role for nuclear imaging is these patients with severe aortic stenosis who are older, prior history of CAD, prior history of bypass surgery. It's very hard to determine which vessel to intervene on when you're planning for a TAVR. We did a study at our center with 50 consecutive patients with severe aortic stenosis. We did PET for these patients. A couple of messages from this is it's very safe to do. This is pharmacological stress testing. There was some fear about doing this in patients with aortic stenosis. That turns out to be a false fear. This is a very safe test. And we can actually localize ischemia very well, and we can guide the interventional colleagues on what vessels and what areas to intervene on, so we don't have to go and stent everything before or after the TAVR. This is the slide that looked at patients with ATTR and aortic stenosis. Again, if you look at patients in general with aortic stenosis, 15% of them will have amyloidosis. If you look at patients with low flow, low gradient aortic stenosis who are older than 80 years old, about 80% of them will have ATTR amyloidosis. So it's very prevalent, at least in the population we handle in the US. And there's some early data showing that probably TAVR is preferable over SAVR in this population because it's less traumatic for these patients. Finally, I just want to emphasize to you the central role of echocardiography in the diagnosis and monitoring of disease in aortic stenosis. CT is replacing a lot of the initial role of transphageal echo for planning for TAVR and SAVR. MRI is now emerging on the scene as a tool to fine-tune the decision-making beyond symptoms and gradients. And finally, nuclear imaging to exclude ATTR and plan for revascularization are wonderful tools to treat amyloidosis if present or to guide revascularization. Thank you.
Thank you, Dr. Jober, for this whirlwind tour of the imaging and management of aortic stenosis, a disease that all of us see very frequently in our practices. I haven't seen any questions coming through from the audience, but I have a couple of questions for you. You had mentioned, obviously, the usual conundrum. Where do you measure the LVOT? The ASC guidelines from 2017 gave a range between 0.3 to 1 centimeters away from the annulus. So what are your thoughts about that? I mean, where do you measure? When you're reading your echoes, where do you measure?
Thank you so much. Thanks, Hiba, for this is one of the toughest questions you can be given. The problem is even the guidelines of AAC, and I'm going to get a lot of flack for saying that in public, they were actually pulled out of a hat. There's no really in vitro measurements that maybe justify what they did. One. Two, it is very easy to do that in the setting of a very controlled setting in a patient that's ideal to image. It is extremely difficult to ascertain that when you have poor imaging. Now, in general, one of the slides I showed you is not to be right at the valve and not to be deep in the LVOT. It's somewhere in the middle, and probably that works best. We are learning a lot from the CT scanning on where to measure this. So there are many studies right now looking at correlating the CT LVOT we get with echocardiography. So that's one. Two, a lot of the papers coming from here, from the Quebec group, from the Columbia group, and others are moving away from this LVOT and trying, because this is the biggest problem we have with echocardiographic measurements, to move away from that and give an index of valve stenosis or valve performance independent of the LVOT.
I agree with you. I mean, and I'm sure a lot of us share the sentiment. It's always very difficult unless you have pristine images and you're absolutely sure of your measurements and how far you measure from the annulus. And from the Quebec group, they've recently also correlated these different measurements with MRI measurements, and they felt the closer to the annulus, that correlates better in terms of the actual measurement.
And it gets more complicated once you're actually assessing prosthetic valves. So let's say you put an S3 valve in and a Medtronic valve in, and you're trying to figure out right now, where do you measure the LVOT? And that's another problem. Not only where do you measure the LVOT, where you put your sample volume. And a lot of suggestions out there in the literature, they're all great, but they need to be verified and correlated with some physiologic in vitro measurements.
Dr. El-Sharkawi, what are your thoughts about measurements
of the LVOT?
Mm-hmm.
It's very difficult, especially in heavily calcified aortic valve with LVH, hypertrophied interventricular septum. It's very difficult, especially with obese females, that elderly female coming for our lab before assessment of aortic valve replacement or TAVR or whatever. So we usually go for 3D echo, sometimes for 3D TE to have better views or better assessment for these patients. I think I'm asking Dr. Wael, do you use 3D echo in these patients, or there's no rule?
Of course we use it. So right now all the vendors have fantastic 3D capabilities. We use it. Again, it's very hard to use it if you have, to get good 3D images, you have to have good 2D images. So the 3D doesn't solve the problem of the obese patient or the patient with COPD where you cannot image. So 3D helps in the setting of when you do a TEE. So if you decide to go for TEE, almost universally you will get good images. And this is where actually right now, almost always I can't remember the last time we have not used that, where we measure the LVOT not only as a one-dimensional structure that we used to do before. We give an LVOT area, and we do that for TAVRs, and we do that for left atrial appendages. So it's all right now with a TEE. You can do that with a surface echo. If you have good images, you have good images. If you don't have good images, you're on your own.
So I'd like to move on from the LVOT measurement, and I would like your opinion about measuring the valvular arterial impedance. Do you use that at all in your practice, especially in low flow, low gradient paradoxical AS?
So we have not, as you well know, incorporated this in clinical decision-making yet. The papers, again, on that are emerging over the past 2-3 years. I think they're going to have more role in patients with post-valve replacement to track these valves, to track these prosthetic valves. In the patients with native valve disease, we have so many other ways of arriving at a good diagnosis. They're going to be the rare patient in 1 in 1,000 where you cannot make a decision on that. And probably that's where you'll compare. But I don't think it is ready for prime time right now. We have the majority of patients, just remember for the audience, the majority of patients with aortic stenosis you're dealing with are going to have straightforward severe aortic stenosis with normal left ventricular ejection fraction. You're going to be fine. Whenever we are in our academic bubble and we talk about all these, rare instances of low flow, low gradient, low flow, low gradient, normal EF, low EF, all these things, these are the rare cases. These are the probably, I would say, 5 to 10% of the general population. And those patients, you have other tools to do it. I have not found the reason to do it right now, and I don't know of any academic lab that has been doing it routinely, except in the setting of clinical research and core lab.
So thank you, Dr. Jaber. We have a couple of questions from the audience. One question is, what's your plan for AS, severe AS with ascending aorta more than 50 millimeters? I guess somebody...
So these are patients who the guidelines right now recommend that they go for valve replacement and aortic replacement. We do not have a solution, a percutaneous solution for the ascending aorta yet. If you're planning to operate on the valve, you should operate on the valve and the aorta at the same time. The cutoff of 5, the cutoff for replacing the aorta is 5.5 by the ACC guidelines. There's some debate whether it's 5 or 5.5, but 5.5 is the ACC the ACHA guidelines to do that. If there is a prohibitive risk to do aortic surgery, or there is a center that doesn't do it, you can proceed with TAVR, knowing that at one point either you're going to have to deal with the aorta, or if the patient has prohibitive risk and their outcomes they're not expected to live 20 years, probably you can get away with it without replacing the aorta.
There are a couple of other questions. What is the best imaging modality in multivalvular disease?
All of them.
All of them.
So there is no, that we used to live all in our tunnels, as you well know, where the echocardiographer would say, this is what solves all the problems. And the CT person says, this is what solves it. Right now, if you're in a modern clinical practice, you have to use all the imaging modalities you can use to arrive at diagnosis. In multivalvular disease, echocardiography is a very good tool. It's a great tool, not only a very good tool. It can assess all the valves simply, non-invasively, and follow up on these patients. Again, you're going to deal with a rare situation where you need an MRI to figure out RV dysfunction, a patient with severe tricuspid regurgitation. You will need it for patient with pulmonary hypertension. You will need it for patients with, let's say, mitral regurgitation and assessing left atrial volumes, left atrial strain. But in general, echocardiography is a good tool. But if you need other imaging modalities, don't be stubborn. Use everything you have.
Hey, Dr. Wael, can I ask you, what's the protocol you're using to do CT for them? Is it 2 injection, 2 acquisition, 1 gated and 1 ungated, or just 1?
So it depends also on the kidney function and all these other things. So when we get these patients for aortic stenosis, we have a TAVR protocol that is out there that we can, if you want, I can share with you offline. So again, it depends on the creatinine, and it depends on whether the patients had a prior just limited aortic imaging without descending aorta. But yes, we use both.
Thank you.
And I mean, in my practice, I also rely quite often in patients that are difficult to assess non-contrast and looking at the calcium score. You have alluded to that on one of your slides, and I found it very helpful in patients where we're not entirely sure, the images are difficult. And I've actually relied on it even more than ordering a TEE on a patient or getting a TEE on a patient.
Absolutely.
So I think Dr. Iman, ready for the next session.
I think Dr. Yasser Sadek is asking a question.
Yeah.
He's one of the speakers.
Thank you, Dr. Wael, for this excellent presentation. I'm asking about how accurately you find 2D TE is accurate for measurement of CT in cases of in patients we can't tolerate to do for them CT, and in the absence of 3D TE.
So it's very good, actually. If you remember, in the first 3 waves of the partner trials and other valves, the TE was the way to do. So if for partner 1, partner 2, and even in the early phase of S3 intermediate risk, the TEE was the way to go, and it was very good, and the results were excellent. You know, remember paravalvular regurgitation, that group was under 2%. So you can still use it. I'm not saying you cannot use it. It's a very good way to do it. But because right now we're moving to less invasive thing, these patients are not under general anesthesia when we do the procedure. So we prefer not to have another tube in their mouth. They're just really breathing freely. We just use CT for the planning, and then we correlate that with the intra-procedural thing. So we use it for the comfort of the patient to minimize risk, and we find that CT is more accurate. It's more precise. As we get patients we move down right now to low-risk patients. You want to make sure that you don't have, you minimize the chance of paravalvular leak, because that can have, a major impact on survival and outcomes down the road. So if you want to use TEE, it's very good, but hopefully everybody knows how to do it very well. And now most of the packages have 3D in them. You should measure it by 3D. You should not rely on 2D imaging.
Thank you, Dr. Wael.
Thank you.
Thank you. I think now it's a pleasure for me to introduce Dr. Mohammed Balghaith, Consultant Intervention Cardiology at King Abdulaziz Cardiac Center. Welcome, Dr. Mohammed.
Thank you. First of all, I would like to thank the organizing committee for inviting us, both Dr. Dibti and Dr. Mohammed Subhi. Today, we'll talk about the management of aortic stenosis patient with the low STS scoring. We know that aortic stenosis, it's a life-threatening disease, and the progression of the disease might take time, but from the onset of the symptoms, 50% at 2 years, the survival will be affected, and 20% at 5 years. The surgical intervention, we know this from the old surgical data, that the surgical intervention for severe aortic stenosis should be performed very fast once even the minor symptoms started. It is not just about the STS risk scoring, and we see this in the real life. Sometimes you will have 2 patients with the same age, like the screen here, but the frailty index is very important. You could have a patient so frail, and in the same time, you might have a patient from the same age but less frail. And this will affect our decision as a heart team. The first TAVR or TAVI performed by Alain Carbier, as we know, in 2002. And this is what was the start of this percutaneous valve replacement. The primary endpoint, as we see from the partner, the old trials, all-cause mortality comparing TAVR with AVR, it was good, especially in the beginning, of the first 12 months, it was in favor of TAV, but this continued to be almost equal results. The partner trial established that TAVI is better than medical therapy in high risk, and TAVI showed a similar result to AVR or SAVR in high risk patient. TAVI is less invasive, as we know now. We are doing TAVI in our center at least for 10 years now. There was a concern with the TAVI patient, especially high rates of aortic insufficiency, paravalvular leak, vascular complication, and other complications like pacemaker. We did see a lot of advancement in this technology from both big companies in the world of TAVI, mainly Edwards and Medtronic. And you can see they improve the situation with the vascular complication by lowering and improving the profile of the sheet. TAVI started with the 22 French sheet. Now we are down to 14. And we are hoping that they might go a little bit down. The problem with the paravalvular leak, they improved the seal of or the skirt of those valves. Both companies, they work very nicely. And you can see the S3, the Sapien 3, which is one of the newest generation now. Sapien 3 Ultra is coming soon. And they work hardly in those valves, which improve the paravalvular leak. The pacemaker situation improved with the technique. We improve our technique, and we are doing more higher positioning and cusp overlapping and commissural alignment. All those technique with the learning curve in the last few years improve the final result. And we can see how this improvement of technology improved the outcome. Partner 2A was using Edwards valve, and it was mainly in the intermediate risk. And the result was excellent, and it was in favor of TAVR. The primary endpoint, as you can see here, both all-cause mortality and disabling stroke. The other company, which is Medtronic, the SORTAVI trial, again, they use their valve in the intermediate risk patient. That's mean the patient between STS score 4 to 8. And again, the result was good for a long time. Partner 3, this is the main subject for today, is the low-risk patient. Do we have data now? Yes, we have a very good, well-designed trial. Partner 3, it was a transcatheter or surgical aortic valve replacement in a low-risk patient with aortic stenosis. And the background, as we mentioned, it was the previous trials. All the trials, high risk and also non-operable and intermediate. Now we left with the low risk, and the Partner 3 was one of the major trials in this field, about 1,000 patients comparing both TAVR and SAVR, head-to-head comparison. And the key inclusion criteria was severe calcific aortic stenosis, patient symptomatic, and low risk, low surgical risk, determined by multidisciplinary heart team, and the STS scoring less than 4%. As you can see here, very good scheme. And also the good thing about it is the follow-up. At the final stage of 1 year, like the follow-up was 98.4%. And this gives this study a very strength. The baseline characteristic, as you can see, one of the issues is the age. And as you can see, those patients who entered the trial was 73 plus minus 5.8. We can say the lower age maybe was on the 67, 67, 68. The primary endpoint, as we can see here, up to 12 months, surgery versus TAVR, or SAVR versus TAVR. You can see the division of the curve very early, even from the first month, and this was maintained up to 1 year. And now we have the follow-up of the 24 month, which is 2 years completely, and it was mainly in favor of the primary endpoint in favor of TAVR in comparison with the SAVR as a surgical procedure. The death, as you can see here, it was at 1 year, it was in favor of, and even the P value was significant for SAVR. There is some matching, although the trend is still in favor of TAVR up to 2 years. The stroke, you can see a more benefit of stroke for the TAVR, some catching around 24 months or 12 years, but still it's less in the TAVR in comparison with the SAVR. Death or disabling stroke almost the same. One of the issues seen was the valve thrombosis, and Dr. Weil, he touched on that with the imaging. In partner 3 trials, the CT findings in the TAVR, there was 7.7%, which is like 1 patient. The echocardiographic finding for the mean gradient, it was almost similar, which is an excellent result for the percutaneous valve, and the aortic valve area was almost similar and maintained up to 2 years. Some difference in the paravalvular leak, and as we know, the BVL or paravalvular regurgitation was more in the percutaneous valves, but still with the new technology, we're having a lot of improvement nowadays. The rehospitalization was less in the TAVR, more in the SAVR, and even the B-value was significant in favor of less TAVR admission or rehospitalization. One of the most causes was congestive heart failure. The secondary endpoint, as we can see here, in the TAVR and SAVR, the onset of atrial fibrillation was more in the surgical group. And we see this even with the CABG in our patient, which is not surprising. And the left bundle branch block, as we can suspect from percutaneous, it was more in the TAVR group in comparison with the SAVR. The partner 3 trial conclusion in a population with a severe symptomatic aortic stenosis patient who were at low surgical risk, less than or STS less than 4, TAVR using the SAPIEN 3 in this trial compared to surgery significantly reduced the primary endpoint of death, stroke, or hospitalization by 46% at 1 year. And increased valve thrombosis event in TAVR patient, especially from 1 to 2 years, and most of those seen maybe by CT scan follow-up. The hemodynamic improvements and frequency of moderate or mild paravalvular regurgitation were unchanged between 1 and 2 years in both TAVR and surgery. The Medtronic also had the trial in the low-risk patient, and it was Evolute low-risk trial, almost in the same time in 2018. And they use also the new valve, which is the Evolute R and the Evolute Pro with a special skirt, which can prevent or decrease the paravalvular leak. And almost the result was good or equal with no inferiority. The primary endpoint MET TAVR is non-inferior to SAVR. And in summary, for the Medtronic trial, TAVR with the self-expanding valves was non-inferior to surgery in patients with a severe aortic stenosis at low surgical risk. Do we have any issue even with the low risk and other people? Yes, it's the durability of the transcatheter aortic bioprosthesis, and there is a special classification. Most of the classification think that it was based on the 5 years durability. There was a concern that in comparison with the surgical bioprosthetic valve, maybe there is an issue of durability question in the percutaneous type of valves or TAVR. They were thinking about the technology of those valves that in TAVI leaflets are thinner in comparison with the SAVR to allow transcatheter device deliverability, which is very good for us. TAVI leaflets experience higher stress and strain, particularly in the presence of calcification. But there is with the new valves like the S3, they are adding anti-calcification element or material. Head-to-head durability of TAVI versus SAVR and NOTION trial, which is a trial done in the low-risk patient, showed a good durability of the TAVR in comparison with the SAVR valve. Dr. Wild Jaber already mentioned something about the thrombosis, which is not a big issue, to be honest with you, but it was more prominent with Portico valve reported by Dr. Makar and his group. And it was most of the cases treated by anticoagulation, and the findings was on the CT follow-up. Unless you see a limitation of the leaflet movement by the echocardiogram and increase in the gradient, then you have to take this in consideration. In conclusion, TAVI should soon become the first option for the majority of our patients, including those at low risk for surgery. SAVR will remain the best option for patients who are not optimal candidates for TAVI and for the youngest patients. Age will become a key factor in the therapeutic decision. In the low-risk population, informing the patients and the relatives about the two options will be essential in the heart team decision. Thank you very much.
Thank you very much, Dr. Belghait. This was a fantastic overview of the partners' trials and so forth. Has Partners 3 changed your practice in Saudi Arabia?
I think it did to some extent. The problem we are having nowadays, even before Partner 3, it is the patient becoming more educated. The program started early in Saudi Arabia, and actually it was started with European, even before some of the United States centers. The problem, as I mentioned, the patient and their relatives now, they are asking for less invasive procedure. But as we mentioned in the talk, there is too many things should be taken in consideration.
And how do you assess frailty? Is it more subjective or is it objective through frailty scores?
I think we are using the score, and you know, the TAVI team, you have nurses with you and you have the junior physician. All those people, you know, they assist the patient very well before he comes to us as interventionists. And I can tell you the people who are not accepted is even by the anesthesia. Sometimes they come one night before, either if they do a conscious sedation, they reassist those patients. They will give you their comment even as a preclinic or anesthesia preclinic. What we are discouraging now, some of our patients, they are a little bit demented. The elderly people above 100, although when we start, we did 105, 102, but they are in a good health. Some of them, they live in the mountain and they don't eat junk food, and they are elderly, but still in a good shape. I remember one from Taif area, which is in the mountain. He doesn't eat any junk food. He doesn't drink, you know, the soft drinks ever in his life. And it's a natural food for him. And he's 105 and his mentality is excellent. Actually, we decided to do a TAVI in him. And the other guy from the southern part, which is nearer to Yemen, very healthy. He's a mountain guy, 102. And we asked him after TAVI not to drive his car. We are having good patient, and a bad patient was living in the city, demented, stroke, cognitive dysfunction. We don't do it, even if they are younger in age.
Can I have a question, Heba?
Yeah.
Thank you, Mohammed, for this. Mohammed Belghait is the governor of ACC chapter in Saudi Arabia. Mohammed, I have two questions for you. One is the recent, because there is just a study, popular TAVI, that using only aspirin. So you're not afraid of thrombosis. Still, we don't have an actual answer regarding aspirin, the P12, the in WAC, or anticoagulants. What is the best for the patient? Because otherwise, no AF patients. But that means, because you have only, and this adding to the second question, because you have only 18 years durability from 2002 to 2020. So durability and thrombosis comes hand in hand. So how can you manage in your practice?
Actually, the usual practice, we are not changing just because of the popular trial. We are giving dual antiplatelet therapy from 1 month to 3 months for the TAVI. If they are not having any stents or any other risk factors like AFib and I still remember some of our patients, even few years ago, they had problem with epistaxis. They are elderly, hypertensive. And one of them, I stopped his dual antiplatelet therapy for a while, and I can assure you, nothing happened. When we think about the TAVI, it is a big stent. It's not a small stent. And the flow and the speed of the flow, it's not like our coronary stent. The concern in the popular trial, because of the side effect, maybe bleeding somewhere else, that's why they suggest one antiplatelet is enough, like aspirin will be enough. And this is what we do even for the regular patient. If they have gastritis or if they have a GI bleeds or something, I end by giving them only Plavix, even if they have TAVI. One antiplatelet will be enough.
Can I ask a question? Go ahead, Dr. Sarkari.
What's the cause of increased incidence of valve thrombosis in patients with TAVI? What the explanation of that? Explanation of increased incidence of valve thrombosis in the TAVI group.
It is almost very rare, but it was with one of the valve, which is, I can say it for sure, it's the Portico valve. From Makar group, they reported like good number, but I think there was a problem, technical problem with the manufacturer. But you could have this thrombosis or leaflet, dysfunction or hypoattenuation in the echo, even with the surgical valve, not only with the TAVI.
Dr. Baki, that was a great talk. Can I ask you, so when you think about, one of the high-risk patients versus a low-risk patient, tell me how your thinking is different in terms of that, because obviously durability is an issue. The partner data certainly shows that there was slightly bit more strokes and death between year 1 and year 2 in the TAVR group. So putting it all together, if I'm a young patient with a low risk, how would you approach me differently than a patient, obviously that's high risk? I mean, I think we're all on board for the high risk patients, but how should our thinking change for these low risk patients?
I think we have different types of valve. That's one thing. When we think about age, this is a big debate. When we go back to the trials, the lowest age, it's still in the 70. Even if you go down, I think we should not put this device in somebody less than 65, at least the data we have. Number 2, it is the technology. You have the subannular and you have the annular valve, and you will be worried from the anatomy and how you gonna engage the coronaries, which is a big problem, to be honest with you. With some of part of the valves, we cannot engage the right coronary very easy. You could engage the left with different catheter, but the right is very difficult. That's why you have to choose the type of valve for those young people because of the anatomy access. And in the same time, I think the age is still important to me. There is some overlap, but we had a big debate in our department just last week about the age, and I took some opinion from UK and France, and I hear that some people, they were fined by doing TAVI in younger age in some of the European countries. The anatomy is very important. Choosing the right valve, you have to have a good communication between you, patient, and the relatives. Tell them about, the difference and what's going to happen, the complication. And the anatomy of the patient, one of them, not only coronary, is bicuspid aortic valve. There is no 100% consensus that it's better with the percutaneous. The main treatment for bicuspid valve till now is surgical, but there is difference in the technology. We have the devices. Some devices, they did better than the others for bicuspid valve.
Thank you.
Dr. Belhaith, I have one last question for you before we move to the next session. What has been your experience with endocarditis and with the TAVR patients?
It is not very high. In our center, since November 2010 till this moment, we had only one case. But I can tell you, to me, it's not a good thing to have it in the TAVI or TAVR valve. It is a bad. If you catch it in the beginning, you will be happy, because our colleague in Jeddah, they had one patient and they catch her in the beginning. They treat her with antibiotics. She did very well. But our patient, she presented late to us with a fever, low-grade fever for 8 days prior to her presentation to our hospital, because she lives outside the city. And the situation was, she came in like sick. And when we did even a CT scan, you see the valve is ugly looking, very ugly looking.
So do you have a protocol for antibiotic prophylaxis for these patients?
Before the procedure, we give antibiotic, like one dose, but not not a routine. Wael, you want to say something?
Yeah, so we have published last year in, I think in CIRC, they experienced a total partner experience with endocarditis, all the partner trials. And the incidence of endocarditis, as has been said, is extremely low, but once you have it, it's fatal. A very high fatality rate, almost 100%. And that is attributed to two reasons. One is, if you remember, partner included a lot of patients who were inoperable or elderly. So if they got endocarditis, they were not operated on. And two, there was reluctance in going in again for these patients. These were patients with prior surgeries, prior issues. It's actually a tragedy if it happens. So it's very rare. Dr. Muhammad said it's, I agree 100%, but once it happens, it's extremely rare. And these patients should be caught very early and treated early. Otherwise, it's fatal.
And there's also been recent data from Medicare data that was published also recently that was in concurrence with your reported results from last year in circulation. So we move on to our next speaker. This is a fantastic discussion. Thank you all. And thank you, Dr. Belhaith, for this fantastic presentation and discussion. Dr. Yasser Sadiq is presenting challenging cases in aortic valve. Dr. Sadiq?
Yes, sir.
Yeah, I'm here. First of all, I would like to thank the organizing committee for this kind of invitation. I'm really happy to share with excellent speakers my cases. We're talking about low-risk patient, but still there is a very high-risk patient, frail patient, and they need a solution for them. I will start with first patient. He's 83 years old male. He's diabetic. He was known as a significant aortic stenosis 3 years ago before his presentation. And suddenly he admitted in the intensive care unit with cardiogenic shock in December 2016 with severe chest infection and intubated for more than 2 weeks. And his renal function was high, and he put it on inotropic support, adrenaline, noradrenaline, and dopamine. And he was, in his history, poorly mobile due to his musculoskeletal problems. And on ventilator, he's semi-conscious, and he started dialysis at that time. And his risk scores is very high. for surgery or for TAVI. And this is his echo, and you can appreciate here how much is stenotic, this valve. And our team discussion what to do in such patient. He was in ventilation, in inotropic support, and the patient is very high risk for severe and TAVR. And we thought, what is his life expectancy in this situation? So the decision at that time to do aortic balloon valvuloplasty to differentiate between if this patient is very sick because of aortic stenosis, or he is very sick with concomitant aortic stenosis because of pneumonia and renal functions. And this is what we did. This is his coronary angiography. And we did just ballooning for this aortic valve. The patient improved after 5 days, and he extubated, and the renal function was improved, and the dialysis sessions was stopped, and the inotropic support was reduced only to noradrenaline 150 mic at the time. So CT was done, and you can appreciate here his mean annulus diameter was 24.6 millimeter, and the decision taking for evaluate R29. And the first difficulty that he has severe aortic regurg from the previous balloon, and also he has a transverse aorta, and so the projection of deployment was difficult. So we did step-by-step deployment of the valve, evaluate R25, and after release of the valve, 5 minutes, we found the valve dancing in the ascending aorta. So to keep the stiff wire through the valve is very crucial, because the valve can go everywhere in the aorta. So many trials was done to get the valve into the descending aorta, not to dancing in the ascending aorta, and can close left main down or close one of the great arteries up. So another 25 millimeter evaluate R valve was deployed and successfully in the place. And after that, because we found there is paravalvular leakage, so post dilation was done by 24 millimeter balloon to reduce significant paravalvular leakage. And you can see here the end result was satisfactory. And because the valve is very dancing in this area, we trying to get the valve, the first valve in the descending aorta, but suddenly this valve is stuck with the second valve. So we kept everything as it. And when we closed the ProGlide, we found small perforation down. So we did graft stent in that area. But very strange that there is a flow in the graft stent. So we did prolonged dilatation with bigger balloon, but no improvement. So another graft stent was inserted inside this graft stent, and this is the final result. The patient improved and discharged from the hospital after 15 days, no conduction abnormality, no more renal dialysis session. His echocardiography showed mild to moderate aortic paravalvular leakage immediately post-TAVI, but 1 month later, the echocardiography showed mild paravalvular leakage and normal LV function, and the patient doing fine till now. My second patient, male patient, 67 years old, he has shortness of breath, orthopnea, paroxysmal nocturnal dizzy, and lower limb edema. And clinically, he's conscious orthopnic. His weight is only 50 kilogram, and his blood pressure, as you see, and he has bilateral diminished air entry at basal lungs. And he was admitted in the intensive care unit with cardiac shock 1 month before second admission. And he has severe chest infection and intubated for more than 2 days. And now he prepared for TAVI, and you can appreciate here he has bicuspid aortic valve, very calcific, and the mean annulus diameter was 22, and the plan to do for him TAVI, but as you can appreciate here, he has significant coronary artery disease, as he has subtotal occlusion of the circumflex and tight lesion at the mid segment of the LAD. Also, his risk score is very high for TAVR. So we thought that we will start to fix his coronaries, and after that we will do just ballooning for the aorta to improve his function. Actually, there is no hemodynamic support, mechanical hemodynamic support in Egypt, except intra-aortic balloon and ECMO in few centers. So when we started to do this lesion, it's very difficult to cross this lesion, and it's not dilatable lesion. So we shifted to the LAD and we stented the LAD. And after that, immediately post BCI, the patient didn't improve at all. His hemodynamics were compromised, and his blood pressure went down, his saturation go down. So intubation and mechanical ventilation started immediately, and the inotropic support also were initiated, and no considerable improvement was achieved. So this is point of no return. Hemodynamic instability, suboptimal coronary vascularization as a circumflex, just not dilated well, and the patient didn't improve at all after his coronary. So we did aortoplasty by 20 millimeter balloon. As you can see here, how much this valve is very tight. And after that, when we did balloon, the patient was arrested for more than 7 minutes. So CPR was initiated, as you can see here, and the decision was taken to do TAVI, and I started to deploy 26 millimeter volute R valve in this situation, because I'm so that after ballooning, the patient didn't compensate the severe aortic regurg. So this is the final release of the valve, as you can see here. And the patient after that, he improved, transferred to cardiac unit. His liver enzymes is markedly elevated. Serum creatinine is raised to 4 milligram per deciliter. His hemoglobin going down to 7 gram. And 48 hours later, all his laboratory results corrected, and ventilator was weaned. And this is his echocardiography. I have problem with the video, but you can appreciate here his LV function improved to about 45%. And there is no paravalvular leakage. Discharged at day 9. Orthopnea, lymphedema, and abdominal distension were resolved. His quality of life was improved, and he is doing well for 16 months till now. My take-home message from those cases: decision-making in high-risk individuals with multiple comorbidities, both as a science and an art. Procedure success critically depends on proper selection, meticulous pre-planning by echo, by CT, and experienced teams, interventional and surgical, and well-equipped units. A good TAVI operator is simply not enough. Heart team is mandatory in those patients. Differentiation between those who are very sick because of aortic stenosis and those who are very sick with concomitant aortic stenosis is very important. So the elephant is in the room. Now we have TAVR option for those who had no TAVR option. What will we now do for those who are deemed too high risk also for TAVR option? Thank you.
Thank you, Dr. Sadiq, for these two fantastic presentations, and what a save for both patients. I'm sure they're very grateful for that. So I believe we have a question from one of our audience. Which is the preferred inotropic in the presence of cardiogenic shock? Norepinephrine plus dobutamine or norepinephrine and dopamine?
Actually, in cardiogenic shock, we started with norepinephrine, and when there is no hemodynamic improvement, we can add dopamine, and if no improvement, we can add third inotropic support as adrenaline or something like that. We have to get hemodynamic, and better than all this is mechanical hemodynamic support. Actually will save the patient better than hemodynamic support, inotropic support.
Yes, sir. Can I have a question to you?
Yeah.
Thank you for this wonderful cases. Yes, sir. Regarding the tradition of using ballooning dilatation of the aortic valve, even now, if you're doing elective TAVI, they don't recommend do pre-dilatation. The only post-dilatation is significant PVL, but otherwise no pre-dilatation except in some situation. The second, that the bailout TAVI. What are the circumstances apart from your experience to use a bailout TAVI in patients with aortic valve?
When we planned, Dr. Muhammad, for ballooning, we have to be ready with the valve. Because the patient, we can expect that the patient can tolerate severe aortic regurg after TAVI, especially in patient with depressed LV function. When we do for them just ballooning, we have to go by small balloon to avoid aortic regurg. But if the patient can't tolerate the procedure, we can go with valve rapidly, like I did in the second case. I didn't plan for TAVI in this session, just to do coronary arteries and just balloon to improve the patient function. But as you follow the case, I did TAVI. There is no option for patient, and the patient saved by this way.
Can I ask a question?
Yeah.
Yes.
Muhammad.
I think Yasser, you did a great job. And I remember in the old days, we have those problem, the valve will bump up and you will put valve and valve. It is less likely now because of the positioning. But I think the situation with those critical patients, like it's totally different. You want to save the patient life. And you might find a arrest during deploying the valve. And the best thing, not only the CPR, just deploy the valve. Just deploy it. A lot of time, just deploying the valve, opening that tight stenosis will save the life and the heart will move again. And I think as Dr. Subhi, we use this bailout or staging or bridging those sick patients with heart failure intubated with balloon valvoplasty, and it works for a few days. But the problem with this is recoiling. You have to put the TAVI whenever the situation is good. And sometimes you might go at one shot, just do the TAVI.
So this is a question for both Dr. Sadiq and Dr. Belghaith. I always find it very challenging. There are different practices. There are some interventionalists that would prefer to do a balloon valvuloplasty in patients who come in with cardiogenic shock versus just going ahead with the TAVR. Is there any value from doing the balloon valvuloplasty? I mean, they will recoil, so why do it in the first place? And when would you decide on just a balloon valvuloplasty versus going ahead with the TAVR?
I think if the patient situation is not bad, like those people with the heart failure, they are not very sick, you can do the staging with the balloon, but make sure they are still in the same unit before they go to the ward, that you're going to do the TAVI in 1 or 2 days. But I think the critical ones, we did that before, intubated, critically ill, I think just make sure that you have the right sizing. If you cannot do CT scan, but most of them, like those who are planned well, they have CT scan or TAVI protocol CT scan already done, and the measurement is already ahead available for us. But I think doing the 2 steps, you have to choose which patient. The best thing is to go with the TAVI. Yeah, sir.
Yeah. This is as Professor Muhammad said, and this is to differentiate if the patient has a lot of comorbidities. We have to differentiate between those patients who are very sick because aortic stenosis. In some situation, it's not clear that the aortic stenosis is the only cause for hemodynamic compromise. So we prefer to do ballooning and wait 2 or 3 days. If the patient improved, we will do TAVI, as Professor Muhammad said, before discharge from the hospital.
One of the things I want to add, we learned those aortic stenosis, we were not dealing with them as we are doing now as interventionists.
Yeah.
And Dr. Ahmed Umran, he's one of the senior guys from Toronto. He came into our place and he was telling us, they die suddenly. They might die at home. And since we start the program of TAVI, we accumulate patient, we do the CT scan, they are at home. And few of them, we call them, like the secretary will call, they said, oh, Allah yarhamu, that's mean he did, and the sudden death is a real thing in those patients who are severe aortic stenosis and like having a severe symptomatic. I think we should not delay them like before. We have to intervene either way, like surgical or TAVI, according to their risk and age.
Yes, regarding the aortic regurgitation, there's a claim that the TAVI is not indicated of aortic. There's some trials or some cases doing this valve. How frequent is the percentage of AI which is contraindicate the use of TAVI? I mean, +2, +3 in the beginning of the using or stenosis, or just +1? Because your patient has more than +2, but this is secondary to balloon, I think. But if you have it from the beginning, how can you decide?
In the beginning, if the patient have combined the aortic stenosis and the aortic regurg, I don't care what is the percentage of aortic regurgitation, especially if the patient has aortic stenosis, significant, more than moderate, and he has the annulus diameter in the range for valve. If he has this criteria, we can do TAVI for him.
We did, Muhammad, some cases, but I think as Yasser said, if you have some calcium, you are lucky.
Yeah.
Because most of them in our area, they have a history of rheumatic heart disease. And it's not a pure aortic regurgitation. Most of them, they will have, like mild to moderate AS in addition to moderate to severe AI. We did only a few cases. It's off-label, but I think we don't have a special design valve yet for the aortic regurgitation.
Yes.
But I think Mohammed's question is I understand if you already have the AI, you're still going to go ahead and proceed with the TAVI. But what about if you did a balloon valvuloplasty and then from the balloon you got more regurg? Is that what you were asking?
Yeah.
Yeah. And would that change what you do in terms of the TAVI? Because now it's something that you created through the balloon.
Mm.
That's why you don't do the balloon unless the valve, if you're doing the TAVI, the valve is crimped already in the table.
Yeah.
Very important.
Yeah.
Now, from the TCT, there was a trial again for the mitral regurgitation, and the situation of cardiogenic shock is mitral clip is life-saving, and there is good data on that. It's similar to what we are talking about.
So we have a couple more minutes, and I have a question for the whole panel. What do you do with patients like they're with moderate aortic stenosis in the presence of heart failure and not necessarily cardiogenic shock? And so I'm alluding in a way to the UNLOAD study, which we don't have the results yet. Do you consider doing TAVI in those patients in addition to guideline-directed therapy? These are patients not in cardiogenic shock, but with moderate aortic stenosis.
Don't have supported data. That's going to be individual decision from the center, from the heart team, and you have to have the surgeon with you.
And I think we contain the conservative treatment of these patients till we have the criteria that which will favor. We have it in the guidelines, but till now we don't have guidelines for these patients. Deputy, do you have anything about the ACC guideline regarding this kind of patient?
No, I think that those guidelines are going to get updated. So no, I don't think I have anything that's the latest and greatest right now.
Okay.
So the guidelines are in the process of being updated, but there are two issues here. The first one is there are some trials or some at least reports right now trying to move the point of intervening on these valves towards the moderate, where they're saying even patients with moderate aortic stenosis have worse prognosis than patients with no moderate aortic stenosis. I think the fear has been mentioned earlier by many speakers, is that we start to liberate introducing these valves in patients who don't need them. The age 65, Muhammad mentioned this earlier, and under. I think once we start being cavalier about putting these valves in patients under 65, these are patients usually with moderate aortic stenosis are going to be younger. They're not going to be the older population. And we don't have any data right now beyond 5, maybe 7 years on the TAVR. 5-year data came from Partner recently, and the 7-year is right now being collected. But I am worried about being so liberal in our use of these valves just because the risk is so low, and creating more disease down the road and more work for our interventionalists, where they come back for another valve and so on and so forth. But I doubt that guidelines will include that population, despite the fact that probably they're a little bit higher risk than others.
I think we are at the end of our discussion. It passed very quickly. Thank you for this fantastic discussion, all the presenters and the discussants. Thank you very much.
Thank you. Thank you all for this wonderful lectures. And I think Dr. Sobhi will have a conclusion.
Dr. Debiti?
Dr. Debiti first.
So first, I just want to thank everybody. What a fantastic group of people with speakers. Thank you to the moderators. As now all of you listening could see why we've had so much fun doing these Middle East conference. And as Dr. Sobhi said at the beginning, we have our 4th Middle East conference on November 21st. So please mark your calendar and please join us again for it. Again, we'll have a star-studded faculty having great discussions. So I just want to thank you from the behalf of the ACC for joining us for this great conference. And I want to turn it over to Dr. Sobhi, my partner in crime in this.
Thank you, Deputy. You know, I think the waves learned us, the COVID pandemic learned us a lot, to stay at home, to stay for 1.5 hours and to listen and to concentrate and to have data. So I learned a lot in the last 6 months. We have 3 topics today: the imaging, then low-risk patient, and then unusual cases. I think we learned from Dr. Jabra regarding either from Cleveland Clinic, Dr. Jabra from Cleveland Clinic, professor of cardiology, and Dr. Heba, also professor of cardiology from Cleveland Clinic as well, Dr. Ayman from Alexandria University. I forgot to introduce them. The imaging, the central role of echo and diagnosis. CT is important for TAVR planning and SAVR. Regarding the nuclear MRI is questionable, but get used for plan revascularization. Regarding the TAVR now, I think it comes to stay. It is a class 1A treatment of all aortic stenosis, starting with inoperable, very high risk to high risk, intermediate now to low risk with the Partner 3 and even low evolute. And Muhammad concentrate on the age. Muhammad Bilghir, thank you very much for your talk. I think it's this is the first talk of Dr. Wael, very excellent regarding imaging. Then come to the intervention part. TAVI should be soon to become first option. Age will become a key factor. Still, we have the durability, the thrombosis, PVL. I think this can be managed in the next few years. We'll have no problem. Even the prevention of stroke, I think we don't have time to speak about all complications, but actually the minimal complication now is TAVI. with more experience, 18 years, no revolution. And this is evident in the cases of Yasser Sadiq. I think Yasser is one of the experts of TAVI in Egypt. He's a young, but he's energetic. He's doing a lot of cases. He's challenging in the National Heart Institute. He's doing a lot all over Egypt and learning a lot of Egyptians in doing TAVI. Now become more popular because of his team of TAVI. And now he's facing complication. I think the best intervention not to do the case is to treat the complication with the heart team. And this is the lesson from TAVI cases. Thank you very much again. Thanks, Deputy, for joining me. And I hope that we have the fourth wave with an, I think, excellent wave like the last 3 waves. And see you soon and stay safe. Thank you very much. Bye-bye.
Thank you very much. Thank you.